Picture this. You're on OB-GYN rotation and an ultrasound reveals a fetus with massive head, bulging fontanelles, and no detectable forebrain. An alarming case of anencephaly. The attending asks, what went wrong in embryology and how could this have been prevented? Welcome to our USMLE Step 1 deep dive into a congenital CNS malformations, hydrocephalus, neural tube defects, and more. This slide sets the stage for a high-yield review covering embryology, clinical science, and prevention strategies you will see on the boards. We will explore conditions like Chiari malformations, holoprosencephaly, and meningoceles with mnemonics to lock them in. For Step 1, these topics are gold. Think neural tube closure, Sonic Hedgehog signaling, and folic acid deficiency. So let's start with an overview of these malformations and how they develop. Congenital CNS malformations begins early. Disruptions in neural tube development between weeks 3 and 4 are the culprits. This timeline shows closure by day 28, driven by genetic factors like Sonic Hedgehog or environmental triggers like folic acid deficiency. For Step 1, note that these defects range from anencephaly to spina bifida, each tied to a specific embryological failure. A classical question could be, when does the neural tube close? Answers: days 21 to 28. Clinically, these malformation causes hydrocephalus or motor deficits. Making prevention key here is folic acid supplementation is a must-know. This slide lays the foundation for understanding the rest. So let's dive into the hydrocephalus next, a condition you will see on the boards. Hydrocephalus is a big deal for Step 1. A blockage in the ventricular system traps cerebrospinal fluid, causing brain swelling and pressure. In adults with a fixed skull, this compresses the brain, leading to headaches and papilledema. In neonates, unfused skull bones allow head circumference to balloon, a key sign on the exam. This diagram shows the ventricles backing up. Think aqueduct stenosis or tumors. For USMLE, know the difference. Communicating hydrocephalus, for example, from overproduction versus non-communicating, for example, blockage. A classic vignette, neonate with a large head and sun-setting eyes. What's the diagnosis? Answer is hydrocephalus. It's testable, so remember the age-dependent effects. Adults get compression, neonates gets macrocephaly. Let's explore the causes next. Hydrocephalus has multiple causes, but for Step 1, the congenital link is the key. Cerebral aqueduct stenosis, shown here on this MRI, blocks CSF flow, causing non-communicating hydrocephalus, common in neonates. Other triggers include tumors, infections, or hemorrhage, but aqueduct stenosis ties to embryology. Symptoms vary. Adults get headaches and vomiting, while neonates show macrocephaly and developmental delay. A classical question is, what congenital condition causes non-communicating hydrocephalus? The answer is aqueduct stenosis. Clinically, think of shunt placement as a treatment, a high-yield detail. For boards, memorize the sun-setting eye sign, downward gaze due to pressure on cranial nerves. This slide connects embryology to clinical presentation, so let's move to the posterior fossa malformations. Posterior fossa malformations target the cerebellum and brainstem, critical areas for Step 1. This MRI shows the region where Arnold-Chiari malformations occurs, often linked to hydrocephalus and neural tube defects. These malformations arise from faulty embryological development affecting coordination and CSF flow. For USMLE, know that Chiari 1 and Chiari 2 are the big players with distinct features you will need to differentiate. A classical question here could be, what structure is affected in Chiari malformations? The answer, cerebellar tonsils. Clinically, these can cause ataxia or brainstem compression, making them high yield for vignettes. This slide sets up the Chiari details, so let's break it the Chiari 1 next. Chiari 1 malformation is a congenital twist. Cerebellar tonsils ectopically sits below the foramen magnum as seen on this MRI. Kids are often asymptomatic, but adults may report headaches or scoliosis later. This slide shows the tonsils downward shift, rarely causing hydrocephalus. For Step 1, it's a subtle condition often found incidentally on imaging. A classical question is, what's a common finding in Chiari 1? Answer, cerebellar tonsil herniation. Clinically, it can lead to syringomyelia, a cervical spinal cord cyst causing dissociated sensory loss. Memorize this as a milder Chiari form distinct from the more severe Chiari 2. Let's explore that next. Chiari 2 ramps up the severity. Cerebellar tonsils and vermis herniate through the foramen magnum as shown here. This leads to non-communicating hydrocephalus by compressing the aqueduct. A step one must know. It's often paired with myelomeningocele, a neural tube defect. This MRI highlights the herniation and enlarged ventricles. A classic question, what's associated with Chiari 2 and hydrocephalus? Answer is myelomeningocele. Clinically, expect developmental delay and brainstem sign like apnea. The banana sign on ultrasound, which shows a flattened cerebellum, is a high-yield imaging clue. This slide ties Chiari 2 to serious outcomes, so let's use the mnemonic to lock this in. Now, let's make Chiari easy with a mnemonic. Chiari 1 stays silent, 2 herniates heavily. 1 stays silent, tonsils below the foramen magnum, often asymptomatic. Chiari 2 herniates heavily, tonsils, vermis, and hydrocephalus. This comparison MRI shows the difference. For step 1, this helps you distinguish them in vignettes. A classical question would be, which Chiari causes hydrocephalus? The answer is Chiari 2. Clinically, Chiari 1 might need surgery for syringomyelia, while Chiari 2 often requires shunting. This mnemonic is your key to nailing those embryology questions, so let's move to the frontonasal dysplasia. Frontonasal dysplasia shifts to craniofacial defects driven by Sonic Hedgehog overactivity. This diagram shows excessive tissues in the frontonasal prominence causing a broad nose and hypertelorism, wide-set eyes. It's a congenital malformation tied to embryology. For step 1, know it's linked to a midline fusion failures. A classical question would be, what gene causes wide-set eyes and a broad nose? The answer is a Sonic Hedgehog. Clinically, it's often cosmetic but can signal deeper CNS issues. This slide introduces the facial features, so let's dive into the details next. Frontonasal dysplasia brings distinct facial signs. Look at this photo with a broad nasal bridge and a widely spaced eyes, plus a midline cleft lip. These results from the failed fusion of a medial nasal prominences due to Sonic Hedgehog overactivity. This slide shows the hypertelorism and cleft nose. For step 1, it's tied to midline anomalies like corpus callosum agenesis. A classical question here would be, a child with wide-set eyes and a cleft lip has what condition? The answer is frontonasal dysplasia. Clinically, surgery may correct clefts, but neurological deficits can persist. This highlights craniofacial abnormality in the embryology, so let's shift to the holoprosencephaly. Holoprosencephaly flips the script. Decreased Sonic Hedgehog activity narrows the face and fuses cerebral hemispheres. This diagram shows severe cases with the cyclopia and a single ventricle called alobar holoprosencephaly. For step 1, it's a spectrum disorder tied to embryology. A classical question would be, what gene defects causes the cyclopia? The answer, Sonic Hedgehog deficiency. Clinically, it's incompatible with life in severe forms, often linked to trisomy 13. This slide sets up the range, so let's explore the semilobar next. Semilobar holoprosencephaly is a milder form, partial separation of cerebral hemispheres as seen on this MRI. The falx cerebri partially forms, unlike alobar complete fusion. For step 1, expect developmental delay, seizures, and hypotelorism. A classical question would be, what's a less severe form of holoprosencephaly? The answer is semilobar. Clinically, it's manageable but requires early intervention. This slide shows the spectrum middle ground, so let's use the mnemonic to tie holoprosencephaly together. Now let's lock in the holoprosencephaly with a mnemonic, SHH, shrinks hemispheres. SHH to Sonic Hedgehog. It decreased shrinks the face and fuses hemispheres, leading to cyclopia in severe cases. This diagram shows the pathway. For step 1, this links genetics to phenotype. A classical question would be, what causes fused brain lobes? Answer, Sonic Hedgehog deficiency. Clinically, it's a marker for trisomy 13. This mnemonic helps with the embryology question, so let's move to the anencephaly. Anencephaly is a devastating neural tube defect. Failure of cranial closure leaves no forebrain, skull, or scalp as shown here, caused by folic acid deficiency. It's incompatible with life. For step 1, it's a classic NTD example. A classic question is, what ultrasound findings suggest anencephaly? Answer, absent cranial vault. polyhydramnios. Clinically, it's detected prenatally with elevated alpha-fetoprotein. This slide highlights the cranial end's vulnerability, so let's explore the microcephaly next. Microcephaly means a small head, less than 2 standard deviations below the mean, as seen in this comparison. Causes include Zika virus, genetic mutation, or fetal alcohol syndrome. For step 1, Zika is a hot topic. Look for calcifications on imaging. A classical question would be, what virus causes microcephaly? The answer is Zika. Clinically, it leads to developmental delay and seizures. So this slide ties environmental factors to brain size. So let's dive into the neural tube defects. Neural tube defects are top congenital CNS issues, forming weeks 3 to 4 due to folic acid deficiency. This diagram shows improper neural plate closure at cranial or caudal ends, leading to anencephaly or spina bifida. For step 1, it's a prevention focus. Supplement folic acid before conception. A classical question is, what deficiency causes NTD? Answer, folic acid. Clinically, it's detectable with alpha-fetoprotein or ultrasound. This slide sets up the defect spectrum, so let's break down the meningoceal. Meningoceal is a neural tube defect where meninges protrude through the vertebral defect shown here. No neural tissue is in the sac, offering a better prognosis than myelomeningocele. For step 1, it's meninges only. A classical question is, what's in a meningocele sac? The answer, meninges. Clinically, it may be asymptomatic or cause mild defects or deficits. This slide highlights a milder NTD. So let's move to the meningoencephalocele. Meningoencephalocele ups the ante. Meninges and brain tissue protrude through the skull defect, often occipital, as seen on this MRI. It's linked to the hydrocephalus. For step 1, it's a midline issue. A classical question would be, what tissue is in an encephalocele? The answer is brain tissue. Clinically, expect seizures and delay. This slide shows a step up in severity, so let's tackle the meningohydroencephalocele. Meningohydroencephalocele is severe. Meninges, brain, and ventricle (CSF) protrude as diagrammed here. The hydro signals high hydrocephalus risk and infection. For step 1, it's a complex NTD. A classical question would be, what's unique about meningohydroencephalocele? The answer is CSF involvement. Clinically, it causes severe deficits and macrocephaly. This slides wrap up the NTD spectrum, so let's summarize it all together. Let's wrap up with these step 1 takeaways. Hydrocephalus from aqueduct stenosis causes non-communicating hydrocephalus. Neonates get macrocephaly. Chiari 2 brings tonsils, vermis, herniation, hydrocephalus, and myelomeningocele. Holoprosencephaly with low Sonic Hedgehog fuses hemispheres, even causing cyclopia. Neural tube defects like anencephaly stem from folic acid deficiency. Use this mnemonic: folic acid saves heads. Folic acid prevents spina bifida, anencephaly, and head defects. This table summarizes it all. A classical question would be, neonate with a large head. Answer, hydrocephalus. Clinically, prevention with folic acid and early imaging are the keys. This review preps you for those neurovignettes. So if it helps, please like and subscribe for more USMLE Step 1 content.